Welcome, everyone. Welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for August 15th, 2018. Thank you for joining our presentation this month. Our presenter today is Brian Pietrosimone. He is an associate professor in the Department of Exercise and Sports Science at University of North Carolina. His research seeks to decrease disability related to knee injury with a focus on maximizing long-term joint health following traumatic joint injury. Much of his previous and current research has evaluated the neuromuscular mechanisms related to disability following lower extremity joint injury. Welcome, Brian.
Thank you. Thank you for having me, and I'd also like to thank the OA Action Alliance for being so interested in secondary prevention. I think Dr. Whitaker had a really nice presentation last month, and I'm excited to continue this discussion on secondary prevention of osteoarthritis. So I'd first like to just define secondary prevention. If we look at the three phases of prevention, we can see that initially primary prevention is thought of as interventions that are taking place to actually prevent an initial injury from occurring. And we've seen multiple types of screening measures as well as primary prevention programs that have been developed to actually decrease the risk of an initial joint injury, oftentimes an ACL injury. On the other end, if we look at tertiary prevention of osteoarthritis is really after osteoarthritis has developed in the joint. And measures are often taken to actually decrease the progression of that disease, as well as decrease the progression of the disability at that point. In between both primary and tertiary prevention, we have secondary prevention. And secondary prevention happens after an initial joint injury, but prior to osteoarthritis developing. So the goal of secondary prevention should be to detect the patients with risk factors of osteoarthritis and to prevent osteoarthritis from occurring, or at least slow down the onset of OA. So today what I'd like to talk about is just one, understanding the risk related to post-traumatic osteoarthritis following knee injury, methods for detecting changes in joint health following knee injury, and then ways we can manage patients who have an elevated risk of post-traumatic osteoarthritis. So really what I'd like to do is provide some evidence of understanding, detecting, and managing this condition, as well as maybe a few pearls that you could use in the clinic in the next few days here. So if we look at osteoarthritis here by the numbers, we see that knee osteoarthritis alone is the 11th leading cause of disability worldwide. We see if we look at it from infants to the elderly, about 5% of the U.S. population has symptomatic knee osteoarthritis. And if we look at over age 40, it's probably closer to 16% of the population. The median age of diagnosis for knee osteoarthritis is 55. So this means that there are a lot of years that are going to be lived with disability in most people. There's a 23% increase in the risk of premature death in people who have symptomatic and radiographic knee osteoarthritis compared to those who don't. So we used to think of OA, as a disease that may cause disability, but not necessarily a premature death. Our idea of OA is starting to progress, and we see this as quite a serious disease that may have effect on mortality in the future. If we look at post-traumatic osteoarthritis specifically, so that is osteoarthritis that occurs following a knee injury, we see that between 12 and 35% of all cases of knee osteoarthritis are due to a previous knee injury. The 35% of number here comes from a military population. So if we're looking at people who are more active and who are more likely to sustain a knee injury, the risk of post-traumatic osteoarthritis is likely higher. Because knee injuries are most common in people who are younger, all right, we see that those who will develop post-traumatic osteoarthritis will likely be younger than those who develop more idiopathic phenotypes of osteoarthritis. PTOA is often found to cause more disability than those who have idiopathic osteoarthritis, and this is most likely because patients with post-traumatic osteoarthritis are younger and may desire more physical activity. And we also often see worse outcomes following joint replacement in those with post-traumatic osteoarthritis, with hypotheses surrounding that being due to the fact that the bones may have changed shape more so in a group who has had post-traumatic injury than those who develop osteoarthritis idiopathically. It's also possible that people are younger, again, with post-traumatic OA, and they want to have more vigorous activity on these prosthetics, which may lead to worse outcomes in that population. ACL injury. An ACL injury has been used quite commonly as a model for understanding the development of post-traumatic osteoarthritis. It's fairly common. This is a population-based study published in 2016. We see that ACL incidence is a little bit higher in males compared to females in the United States, and that's likely due to American football. The incidence for ACL injury occurs a little bit younger in females compared to males. And if we look at those who go on to get reconstructed, many of these people following injury will go on to get reconstructed to acutely stabilize the joint, as well as to promote return to cutting and pivoting sports. We see that 75% of the population will go on to get reconstructed. And if we look at people who are under age 18, all right, it seems to be actually higher. Almost 98% of individuals will go on to get reconstructed. While reconstruction is supposed to increase our ability to stabilize that joint acutely and allow us to go back to those running, jumping, pivoting sports, there's still debate on whether ACL reconstruction actually decreases the incidence of osteoarthritis. This is a meta-analysis that we did a few years back, and we looked at the prevalence of ACL reconstruction in those who were, the prevalence of post-traumatic osteoarthritis in those who were reconstructed versus those who remained deficient. And what we saw is in that first decade, it was fairly similar prevalence between this group, these two cohorts of individuals. So about 36% of ACL reconstructed people went on to develop post-traumatic osteoarthritis within that first decade. And in the group who remained deficient, it was about 34%. If we looked at the second decade, we saw that the number jumped to 48% in the group who went on to get ACL reconstruction. So what we see is within that first decade, 1 in 3 people will develop post-traumatic osteoarthritis regardless of their reconstruction status. And by that second decade, it's about 50%. So it's basically a coin flip on which patients will go on to develop knee osteoarthritis. We also see that among clinicians, there's a perception issue on regarding arthritis. This was a study that we recently published where we surveyed about 2,000 athletic trainers around the country who are treating people with ACL injury. And we asked them questions to determine their knowledge and perception of post-traumatic osteoarthritis, following ACL injury. And what we saw is that 40% of clinicians were actually unaware of post-traumatic osteoarthritis. And when asked if their patient developed osteoarthritis, would they consider it a major health concern, almost 40% again suggested that it would not be a major healthcare concern. They consistently underestimated the prevalence of osteoarthritis in that first decade, and not surprisingly, but they overestimated the benefit of ACL reconstruction in reducing the risk of developing post-traumatic osteoarthritis. So what we're seeing here is that our clinicians who are actually treating people right after ACL injury are not necessarily aware of this problem. And if we look at the years of clinical experience, we see that our younger individuals probably are less aware, less likely to explain the risk of osteoarthritis and provide prevention strategies to our patients compared to our more experienced clinicians. So currently, if we look at the standard of care, what we see is that we have our day one of our ACL injury. We have our ACL injury and rehabilitation that might last between day 2 and 9 months after reconstruction. And then we have a period of time, all right, between 9 months and 10 years where patients go back to physical activity, and 10 years later they come in with knee osteoarthritis. And what we're not really doing a good job of is that secondary prevention in that shaded area there where they're returning back to physical activity. When we talk to clinicians about why we're not doing much at this time, we often hear, well, we don't really know how to detect which patients are going to go on to develop early post-traumatic OA, and we really don't have great ways of managing early PTOA. So I'd like to try to tackle those 2 points and touch on a few ways that we can look at detection and management early after injury. So if we look at detecting changes in joint health, most commonly we use X-ray. And Torville et al. Out of Vermont actually showed that at 4 years after ACL reconstruction that there was joint space narrowing in about 30% of ACL reconstructed individuals. But if you look at the interlimb differences, they're quite small, and this method of detection requires a highly sensitive degree of sensitivity to actually detect these changes. If we look at more clinical ways of detecting osteoarthritis using the Kellgren-Lawrence scoring system, which really looks at development of osteophytes and joint space narrowing on clinical exam, we see that these traditional methods are not really sensitive enough for detecting the earliest changes in joint health. And by the time our patients have osteophytes and joint space narrowing, the structure of that joint has already changed, and reversal is not really possible. So it's been suggested that in order to detect this process earlier, we need different measures, including both molecular and pre-radiographic imaging, in order to determine who will be more likely to develop osteoarthritis in the future. So we recently conducted a systematic review where we looked at fluid biomarkers in people who had ACL deficiencies and those who went on to have ACL reconstructions to determine if there were any blood, urine, or synovial fluid markers that would be able to predict the development of osteoarthritis. And to basically cut to the chase of this review, the takeaway points were that there were, alterations in type 2 collagen and proteoglycan observed in both synovial fluid and blood markers. There was an inconclusive response from inflammatory cytokines, and there were really no clear early soluble biomarkers of PTOA following ACL reconstruction. So there's still a lot of work in this area to be done, although we can detect changes in type 2 collagen and proteoglycan. MRI has been used quite frequently, and what I'd like to do here is just provide some data of changes, abnormal changes that are occurring in the cartilage and the bone following ACL injury. But it should be noted that there are no formal MRI universal definitions for early osteoarthritis. One of the first things that we see initially following an ACL injury is a bone marrow lesion, which often will occur on the femur and the tibia due to that rotational force that's caused following or during that injury. About 63% of people have a bone marrow lesion on that lateral condyle of the femur following ACL injury, which seems to resolve over time. What we do see happen is that these traumatic bone marrow lesions might actually, while they resolve, we see chronic femoral bone marrow lesions develop in a proportion of knees at 2 years. So what may be happening is that while we have an initial, while the initial bone marrow lesion resolves, new lesions may occur, later on, and this could be due to changes in how that joint is being loaded. We also see very early on, within those first 2 years, a change in the composition of the cartilage. This is a measurement called T1 row, and you can see the ACL reconstructed limb and a contralateral limb, uninjured limb, a heat map here that is actually evaluating relaxation times of the cartilage. And these relaxation times are associated with proteoglycan changes in the cartilage. And what we see is that at 1 year, while there might not be changes in the thickness of the cartilage, we are actually able to see that there's a change in the composition of the cartilage very early following ACL reconstruction. You can see here that these hotter or more yellow-red relaxation times in this ACL reconstructed limb are associated with less proteoglycan density compared to the contralateral limb, which has a higher proteoglycan density. We see these changes have been seen at 1 year, 1.5 years, and 2 years following ACL reconstruction. So these changes are happening quite quickly following the initial injury. If we look at cartilage thickness, what's seen is that oftentimes the cartilage thickens in the early first 2 years post-ACL reconstruction, and then may actually thin at 3 to 6 years after ACL reconstruction. So it's possible that the initial response from the cartilage may actually be to swell, which is a bit counterintuitive, prior to it thinning later on after injury. Finally, at 5 years, the Canoon trial is reporting that patients are actually having a change in the bone structure. So we're seeing that there's actually a flattening of the femur and an increased depression of the tibial surface. So by 5 years, we're actually seeing the subchondral bone is changing shape in these patients. So I basically put this MRI summary timeline together, and what I wanted to show here was not necessarily that these physiologic changes actually stop at these time points, but there's a lot of time points that we just don't know yet. So, future research needs to kind of continue to evaluate these changes in both bone and cartilage to understand a little bit more about how this physiology is changing after injury. We also see that there might be more clinical ways of measuring cartilage following injury. And one of these is using ultrasound to measure cartilage thickness and cross-sectional area. So here you can see a picture of the subchondral bone and then a measurement of both cartilage thickness and cross-sectional area. And the upper portion here would be the soft tissue over the top of the cartilage. And what we've seen in our lab is that this is another measure that we could use to actually see that early thickening of that cartilage in a group of patients who are ACL reconstructed. We looked at their ACL reconstructed limb compared to their contralateral limb. And on average, their cartilage was thicker and had a larger cross-sectional area, similar to those MRI findings. Finally, we could look at patient-reported outcomes to detect those who are having significant changes in their quality of life. So the KOOS has been used in 3 different methods to determine patients who may be having a poor outcome following ACL reconstruction. The first method kind of looks at the quality of life subscale being less than 87.5, and then 2 or more of these other subscales being present. And the second one method actually looks at a pain score, and then we have a third method that looks at a minimally clinically important difference in patients if you're able to measure them over time. If we look at these cutoff scores, we can see that this first method in the MOON study, which is one of our largest longitudinal trials in the United States after ACL reconstruction, has shown that approximately 43 and 39% of individuals would actually be classified as having a poor outcome, which is pretty similar to the amount of patients that we would expect to develop in that first decade. It seems that the method for pain, the second method, might underestimate, and then that third method with the change also having a lower amount of people that are classified as having a poor outcome compared to that first method. We think that the KOOS may be a good way also for detecting underlying changes in composition, as we found that changes in cartilage composition in that lateral femoral condyle where that initial bone bruise likely occurred is significantly associated with 4 of the 5 subscales of the KOOS at year 1 following ACL reconstruction. Finally, another indicator of PTOA that we might be able to look at in the clinic might be walking speed. Walking speed has been reported to be a 6th vital sign due to its generally stable nature until the 7th decade of life. Habitual walking speed, slower habitual walking speed, predicts the onset of idiopathic osteoarthritis. And we see that it's a very small decrease over a 12-month period that might actually increase someone's risk of idiopathic osteoarthritis. We asked the question recently, can walking speed predict PTOA following ACL reconstruction? What we looked at was our cohort of patients at 6 months following ACL reconstruction. We looked at their walking speed during a self-selected gait trial. And then we looked at 12 months to determine if this would be associated with their 12-month T1 row MRI, which is measuring proteoglycan density in the articular cartilage of the femur. What we found was that in that medial condyle of the femur, that slower walkers actually had higher T1 row relaxation times, suggesting that those who walk slower after ACL reconstruction actually had lower proteoglycan density at 12 months. Additionally, we looked at a separate group of individuals who are a little bit later post-ACL reconstruction, about 4 years. And what we saw was that, again, those who walked slower actually had higher serum C2C concentrations, which is a biomarker of cartilage breakdown. So these data might suggest that walking speed in the future might be a good way of clinically measuring who may be having poor outcomes following ACL reconstruction. So finally, how can we go about managing our patients with elevated risk of PTOA following injury? So it's important to know there's no disease-modifying interventions for post-traumatic osteoarthritis at this point, but we should know that we can do something. Most guidelines that we see, and one of these papers is Nelson et al. From 2014, are for idiopathic osteoarthritis. There's not a lot of guidelines that are written for secondary prevention. So in this case, I think our best current practices would be serial assessment, education, proper strength and mechanics, activity modification, and weight management. And I'll go through a few of the evidence surrounding these right now. So I think one of the mistakes that we often make is after someone returns to physical activity after ACL reconstruction, we oftentimes do not follow up with these patients. This is a study by Rugg et al. In 2014 where they looked at patients who had an ACL reconstruction and their risk of an additional knee injury in the next 2 years. What we saw is that only 10% of patients remained knee injury free at 2 years. So this suggests that there's a high susceptibility for sustaining another injury, which we know would increase that risk of post-traumatic osteoarthritis within that first 2 years after initial injury. So when we're looking at serial assessments, we should think of that first 2 years following the ACL reconstruction as a time frame that is necessary to continuously follow up with our patients. We should also educate our patients a bit better. This was a study from colleagues in Australia where we looked at patients who had an ACL reconstruction, and we asked them their knowledge and perception of post-traumatic osteoarthritis after a knee injury. What we saw is that only 27% of ACL reconstructed patients discussed the risk of post-traumatic OA with a healthcare professional. And 65% believed that ACL reconstruction would actually decrease the risk of post-traumatic osteoarthritis. And what was a bit embarrassing was that our U.S. patients, only about 7% of them believed that osteoarthritis was a major healthcare concern. So I think if we look at our other study, we saw that in our clinicians, who 93% of them treated patients with osteoarthritis or with ACL injury, they believed for the most part that ACL injury would increase the risk of osteoarthritis. They thought it was appropriate to talk to the patients about the risk. We see that it really falls to 71% who actually explained and provided strategies. So we still have a gap between knowing that there is a risk, knowing that we should talk to our patients about it, and then actually doing it. When it comes to what types of interventions we should be incorporating in prevention, I think one of the common ones is actually maximizing lower extremity strength, particularly quadriceps strength. Quadriceps weakness has been linked to joint space narrowing in ACL reconstructed patients at 4 years of following ACL reconstruction. And in one of our largest meta-analyses to date, we see that quadricep weakness actually increases the odds of incident OA in all people who develop osteoarthritis. We've recently found that in our patients only 6 months out of ACL reconstruction that our weaker patients actually have less proteoglycan density in their femur, suggesting that very early weakness at 6 months following ACL reconstruction may be associated with these early cartilage compositional changes that are occurring at the knee joint. So how should we go about actually improving quadriceps strength? And I'm sorry here that this is a PDF rather than a PowerPoint slide. But what we looked at in this group of people was in about 96 people with unilateral ACL reconstruction. We tried to determine what the quadriceps strength needed to be in order to report high self-reported function, which we defined as 90% on the IKDC. What we saw is if we looked at quadriceps strength normalized the strength of the opposite limb, that patients actually had to be 95% compared to the opposite side in order to have the highest sensitivity and specificity of predicting a high self-reported function. And it was about 3 times greater odds if they were symmetrical. We also looked at comparing quadriceps strength to the mass of the patient. And what we saw is that people who were able to actually achieve 3.1 Newton meters compared to their own body weight were 8 times more likely to achieve high function. So this suggests, the takeaway point from this is that we need to be testing not only symmetry, but also how sufficient the quad strength is compared to a person's body weight. The reason that muscle strength is important is that it affects how we actually move. So it's thought that quadriceps weakness would cause more of a stiffened gait strategy while people are walking, and this stiffened gait strategy would actually increase compressive loading at the knee joint. What we're also finding is that, decreasing load is not necessarily what we should be aiming for. So what we were seeing is that those who actually come in with lesser loading on their injured side compared to their uninjured side early after ACL reconstruction may also be problematic. So lesser loads are associated with higher cartilage breakdown. And we see that lesser loading at 6 months actually is associated with worse self-reported outcomes at 12 months. So really what we should be aiming for in our patients is to optimize load, and that offloading and overloading may also have very similar consequences when it comes to OA development. It's important to remember that encouraging exercise is important for our patients, and we need to make sure that we instruct people to have safe exercise on an individual patient basis. So after injury, we should not be suggesting that they take on new high loads like ultra marathons if they have not already been doing that. Obviously, the idea of having multiple injuries may increase our risk of post-traumatic osteoarthritis. So finding ways for patients to go on and take on safe types of activities that do not increase that risk is important. Furthermore, making sure that they have the proper muscle strength and mechanics to perform those activities will further decrease that risk of that second injury. We see that overall athletics does not seem to increase the odds of developing knee osteoarthritis, but there are certain high-risk certain high-risk sports, including elite level distance running, competitive lifting, and wrestling. There has been some data to suggest that there's significantly higher increased odds for developing osteophytes after ACL injury in athletes, but there doesn't necessarily seem to be a link between habitual running and the increase in progression of osteoarthritis in those with knee osteoarthritis. Finally, maintaining a healthy weight seems to be one of the most common guidelines for decreasing that risk of post-traumatic osteoarthritis. BMI is still one of the most predictive risk factors for idiopathic OA, and knee injury coupled with weight gain may increase our risk of developing osteoarthritis. What we do see is that it's not clear how much of an increase is actually in weight is actually going to increase someone's odds of developing knee osteoarthritis. There's been some data to suggest that an increase of 10 pounds of body weight is proportional to an increase of 30 to 60 pounds of force at the knee joint. What we've seen in a larger cross-sectional cohort of individuals where we looked at the association between body mass and self-reported function is that there really wasn't an association in the first few years after ACL reconstruction between body mass index and self-reported function, unless we separated the group by those who were obese and non-obese. When looking at the association between BMI and cartilage turnover, what we see is very early on in those first 3 years that there was a slight or a moderate association between increase in BMI and cartilage turnover in females. So overall, if we look at what we've talked about today in these 3 categories, these are the main points. For understanding the risk, OA is a major healthcare concern. There's no single pathway to developing post-traumatic OA, and multiple tissues can be affected. ACL reconstruction does not significantly decrease that risk, and 1 in 3 people will develop it within that first decade. As far as detecting the risk, our traditional x-rays may not be sensitive enough. While there's no formal soluble biomarker for OA, there are some key MRI features that might help us detect significant changes at that joint. And the use of self-reported function and walking speed may be easy clinical measures that people can use to determine who may go on to develop knee OA. As far as managing that risk, serial assessment is important even after returning a person back to play. Educating the patients about the risk of a chronic disease following an initial injury is important and is not being done enough. Sufficient and symmetrical strength as well as proper biomechanics, smart activity modification, and maintaining a proper body weight are still among some of the more important methods for managing this risk of secondary OA. Thank you very much.
Thank you, Brian, for that presentation. So we realize that it's after 12:30, so if you have to log off, that's fine, and we appreciate everyone for tuning in. We still have time for questions, so if you have one, you can type it in any of your questions into the chat box in the right bottom corner. Well, Brian, I do want to say that for our injury prevention group that we have at the Alliance, we are currently working on a toolkit for athletes. So the information that you provided on secondary OA prevention was very informative and prevalent to, that would help us develop the toolkit. So we appreciate you explaining everything that you did.
Thank you.
Does anyone else have any questions or comments? Okay, so Carla asked a question. She said, is there a way to measure NM/kg in the clinics?
We measured ours on a isokinetic dynamometer. I know some clinics have them, some don't. We did all of our measurements in 90 degrees of knee flexion and isometrically. And the purpose for that was to maybe allow for more generalizability to the clinic at multiple time points following injury. I think that this Newton meter per kilogram measurement obviously could be done on any dynamometer. It could also be done, I guess, with a handheld dynamometer. Depending on if you're getting newtons out of that, you might just have to measure the actual moment arm, or so potentially adding in the length of that tib in order to do that. And then kilograms is just the patient's mass.
She said yes, and
question?
thank you. Did anyone else have any questions? Okay, well, it looks like no one else has any questions. Thank you again, Brian, for your presentation, and thank you, everyone, for joining us today. Make sure you tune in next month for our webinar, which will be on September 26th with Dr. Shannon Mialko on self-efficacy in adults with overweight or obesity from the IDEA trial. Thank you.